Good morning. I would like to welcome everyone to the MD Anderson Cancer Center Enjoy Science seminar. This is a series of lectures given by MD Anderson faculty member and is organized by the Office of the Chief Scientific Officer, Dr. Giulio Daetta. My name is Alessandra Ferraioli and I have the pleasure of hosting this series with my colleague, Dr. George Kellin. The goal of the Enjoy the Science initiative is really to strengthen the connection between the scientific and the medical community at MD Anderson and our colleagues, our patients, and our friends around the world during this time when interactions are limited. And there is also less time for doing the things that we love, either interacting with patients, working at the bench, or doing other clinical activities. Today's seminar is being recorded. It will be made available on the Joy Science website later this week, and it's my great pleasure to introduce the speaker of today, that is Dr. Dimitrios Kantoyannis. Dr. Kantoyannis is the Texas 4000 Distinguished Endowed Professor in the Department of Infectious Diseases at MD Anderson. He is also Deputy Head for Research of the Division of Internal Medicine at the University of Texas MD Anderson Cancer Center. He also has a large number of titles and honors, and most important, he is a world-known expert and really the probably best-known authority in the field of mycology. This is through work that has done through his extensive publication and through the work that he has with his medical and translational mycology group. Dr. Kantoyannis will be presenting today an exciting topic that is how transformation in the management of hematological cancer will impact the invasive fungal disease ecosystem. So thank you again for being available to present in Enjoy the Series, and I now give the microphone to Dr. Kantoyannis.
Okay. Good morning, everybody. Thank you, Dr. Ferraioli, for this most kind invitation. What I'm going to do in the following 45 minutes or so is to give you a quick overview of changing landscape of fungal risk as it relates to novel modalities, the way we treat leukemia and to some degrees lymphomas. Reflecting back to the major events in supportive care of cancer as it relates to infections, we go back to 60 years from the early pivotal work of Dr. Freireich and Bode when they were at NCI, when the first Freireich has developed new modalities with platelet transfusions and decreased the death from bleeding in kids with ALL receiving chemotherapy. Then, around the time, pivotal autopsy studies at NCI showed that neutropenia was the major risk of death in leukemia patients receiving cytotoxic chemotherapy. That was the only thing we have and we had for a long time in treatment of hematologic disease. And in early 60s, the realization came that the major bugs that will kill in the patients after platelet transfusions decrease the death of bleeding was Staph aureus infection. That became less of a problem with the introduction of the staphylococcal beta-lactams, nafcillin, and the staphylococcal beta-lactams, such as cephalosporins. In the 70s, patients were dying from gram-negative sepsis. The fear complication of chemotherapy, neutropenia was Pseudomonas, and to less so other gram-negative frauds. And again, new antibiotics, improved antibiotics, typically beta-lactams were introduced, and the problem of gram-negative sepsis remains, but less so compared to other opportunistic pathogens that started becoming a problem in the setting of better antibiotics. So in the 80s, invasive candida was realized as another cause of death in patients with acute leukemia. And the big revolution in the cancer field was the introduction for the first time of potent oral drugs, such as fluconazole in the early 90s. Fluconazole being a drug that has no mold activity against aspergillosis led to an ecological vacuum of new threats by invasive molds, typically invasive aspergillosis in the late 90s or 2000s. And then there have been a revolution in antifungal drug discovery from the early 90s to the degree that we have now over 12 FDA-approved drugs that belong to 3-4 different classes of antifungals that deal to a lot of degree with Candida molds, including resistant molds. However, host-related issues are the main driver to morbidity and mortality due to fungal infections. So what I'm going to try to give a macro view of the 2020s and forward was how the fungal field is intertwined and interrelated with the era of exciting targeted therapies for hematologic malignancies, immunotherapies, and also give a quick overview of the improvements in allo-BMD procedure. There have been several studies, one published last week in Annals, documenting that the causes of death post-transplant attributed to non-hematological causes, such as infections, VOD, bleeding, have been less and less. And now post-transplant malignancy relapse has emerged as one of the dominant causes of mortality. So the transplant field has been exploding in terms of the number of procedures, both autologous and allogeneic. The early improvements in the early 90s was the reduction of transplant-related mortality due to better transplant procedures, reducing density conditioning, use of peripheral cells as a source of transplant, and very effective strategies to control CMV, which is a very immunosuppressive herpes viruses that sets off the patient to a series of events of more immunosuppression and more infections downstream. In the about 10 years or less so, expanded donor pools, such as haploidentical transplant, increased work in the graft versus host disease biomarker and targeted immunosuppression, more refinement to the graft versus tumor effect versus the broad graft versus host disease problem, and microbiome studies are setting up a very exciting field for the allo-BMT for further decrease in the leukemia-related mortality in this patient population. But I think everybody would agree that the most palpable excitement in the field of leukemia has been the explosion of new drugs in the setting of acute myeloid leukemia and acute lymphocytic leukemia. As you can see in this slide, there have been increased introduction of drugs for treatment of lymphomas, a lot of drugs for treatment of multiple myelomas, and CML that is now considered a disease that is about to be conquered to some degree, but there have been a lack of exciting drugs for the treatment of acute myeloid leukemia that was relying on the traditional 7-3 induction regimen for many decades. However, in the era of molecular profiling and genomic profiling, a plethora of druggable targets have been uncovered for the last 10 years. The most prominent one being the FLIP3 mutations. And this has led to an explosion, I would say a renaissance in treatment of new of AML that is summarized in the slide, novel cytotoxic chemotherapies, immune checkpoint inhibitors, an area I'm going to talk a little bit later. Targeted therapy, typically FLT3 inhibitors, novel therapies such as gemtuzumab and other monoclonal antibodies. And our leukemia colleagues are working hard and with an innovative way to try to see what is the combination therapy based on patients' frailty, comorbidities. For example, epigenetic inhibitors are most of the times combined with targeted therapies to avoid the profound cytotoxicity associated with the classic cytotoxic agents. The problem there arises with all these drugs, and you can see here several drugs that have been successfully introduced in the acute leukemia field. Those drugs have a problem of drug-drug interactions with the workhorse of antifungal prophylaxis, which is azole prophylaxis, typically posaconazole, because all those drugs are metabolized through the CYP3A4 enzyme of the P450 demethylase, and this produces a relatively narrow therapeutic index for a lot of these drugs, especially QT prolongation. And this has been one of the major areas, and our PharmDs here have been doing some nice work with us, trying to define what is the most safe azoles to use in the setting of treatment with the new leukemia drugs. And also, as I said before, acute leukemia, a disease that when I was starting my career was not thought to be a disease that has a major immunological component, now is an area of increased targeting with monoclonal antibodies and checkpoint inhibitors. So at this point, the other big revolution in the setting of lymphoid malignancies, typically ALL lymphomas, and maybe to some degree acute myeloid leukemia, is the realization that you can engineer T cells with chimeric antigen receptors targeting antigens in the blast. And by doing that, you create a profound anti-tumor environment at the expense of profound, in some patients, cytokine storm and prolonged cytopenias. And our institution has been a leader in defining those toxicities and having an organized approach how to grade them and how to treat them. But let me give you some examples from the mycology literature about some scenarios when the new therapies can be good or bad or ugly as it relates to mycology, an area that now has increasingly becoming a niche area with specific target populations treated with specific agents or specific sequence of agents with less or more fungal risk. We have moved away from the broad scope of mycology. You give a cytotoxic chemotherapy, you have 3 weeks of neutropenia, and you get a fungus, to an area now we have very good antifungal prophylaxis, reasonable diagnostics, and increased risk based on specific targeted therapies for leukemias. So one area that you see less of a risk in fungal risk is the area of MDS with the use of hypomethylating agents such as decitabine or azacitidine. Those agents, as you know, reverse the aberrant DNA methylation, decondense chromatin, and activate the prior silencing tumor suppressor genes, and they induce cellular differentiation and apoptosis. And studies have shown that using those drugs is equivalent to best supportive care and low-dose RSC in high-risk disease patients and superior to low-risk disease. And again, as you know, MDS is a disease typically seen in more elderly patients with a lot of friendly index compared to young patients with acute leukemias. And Studies on that agent, on that space have shown that compared to cytotoxic chemotherapy, given azacitidine is associated with um, decrease overall frequency of febrile episodes and very low fungal risk. Only 4 invasive fungal infections documented in this particular study presented by Feno et al. With an incidence of less than 0.5% per treatment cycle and 3.3% among patients with prolonged grade 4 neutropenia. So fungal risk is not that high in patients given epigenetic blockers, and antifungal prophylaxis in those patients might not be needed. The bad in this area of new molecular target therapy has been the increased concern that some of these small molecule kinase inhibitors that target immune signaling pathways have basically collateral effects and off-target effects that in some patients who don't quite understand yet, might result in increased fungal risk. And we have put basically a call to arms here in our infectious disease community a couple of years ago, trying to increase the awareness of this problem. The prototype of the problem is a game-changing drug called ibrutinib that has been a very impressive drug for treatment of CLL and several non-Hodgkin's lymphomas. And as you know, ibrutinib is an inhibitor for Bruton tyrosine kinase, and by doing that, it inhibits downstream events in signaling that promote cell survival, proliferation, activation of the tumor clone. And pivotal studies, some of them led by our leukemia colleagues here, have shown that the progression-free survival and overall survival was pretty favorable in patients treated with ibrutinib in CLL compared to the classic treatment of CLL that was chlorambucil-based chemotherapy. But however, although this has not been shown very much in the randomized control pivotal studies that speak to some degree to the relative selectivity of people who go to those randomized control studies, excess fungal risk, typically pneumocystis and to some degree cryptococcus and molds, such as aspergillosis, have been noted. Especially in some selected experience with CNS lymphoma, an untreatable disease. This study here that was published in Cancer Cell by my prior mentee in my lab, Michael Yonaki, showed that those patients had an astounding rate of 39% of invasive aspergillosis, typically aspergillosis of the central nervous system, a very uncommon scenario, even for the average patient with AML with aspergillosis. And that was one of the early experiences published in the area of fungal risk with ibrutinib from the French consortium a couple of years ago, that basically also documented the high risk for CNS aspergillosis and made the observation that has been made again and again in hematology field, that most of those patients were heavily pretreated with other chemotherapies before and had refractory or relapsed underlying disease. And not uncommonly, those patients had other predisposing factors such as neutropenia and corticosteroids. So in while that happens, again, this is an area of intense investigation in the experimental fungal immunology. Early studies have suggested that the susceptibility of mice to aspergillosis with genetic or pharmacological ablation of Bruton tyrosine kinase inhibitor is enhanced. However, this is part of the story because knowing from the genetic deficiencies with Bruton tyrosine kinase inhibitors, those kids do not get aspergillosis. So most people think this is a very pleiotropic immune deficit associated with ibrutinib, and the hope is more specific ibrutinib-like drugs that are being introduced are going to have less of the problem of CNS aspergillosis. And in the review of the literature, basically the summary of ibrutinib and aspergillosis is that CNS disease is a unique feature of this excess risk. About most of the patients with aspergillosis had aspergillosis in the CNS. The fungal risks tend to appear in the first 4 months after ibrutinib therapy. Interestingly, a lot of those patients have a pre-existing brain pathology, and the observation is driven from the NIH experience with the CNS lymphomas. And as I said before, consistent with other observations with other drugs in hematologic disease, fungal infection has become a disease of patients not early in the natural history of leukemia, but kind of late in the refractory relapsed stage. In our experience here, and this paper is already accepted in leukemia and lymphoma, the question is how common the fungal problem is in CLL in patients treated with ibrutinib. And most of the studies suggest it's a real problem, but not a common problem. And this creates a big difficulty. What is the best strategy to pick up early fungal infection in this patient, and what is the best prophylaxis, realizing that ibrutinib has strong interactions with most of the oral azoles. In our experience here at MD Anderson, for the last, say, 2014, 2018, with 848 patients with CLL, only 2.5 patients, and this has been the observation in real-life kind of cohorts, about 3% had proven or probable invasive fungal infections, most of the time pneumonias, and again, aspergillus was the most common problems. In our experience, patients with monocytopenia and heavily pretreated CLL who had the highest risk, and we are trying to expand on this experience and trying to devise some reasonable prophylaxis studies in this high-risk population. But ibrutinib is one of the prototype of kind of a niche risk in patients with malignant disease given small molecule kinase inhibitors. As you know, there is an explosion of this type of molecularly designed drugs, BTK inhibitors, SYK inhibitors, NOX inhibitors, JAK-STAT inhibitors, and also increased use of those drugs in non-hematologic disease such as, say, autoimmune disease. So I think the future is going to be quite interesting seeing patients, and I think one of the messages for the oncologists is to have an open mind and think of fungal disease beyond the classic prolonged cytopenia or steroids, as those drugs might have in some patients, and more work is needed, excessive fungal risk. Just to give you how spectacular this can be, a drug called sorafenib, that the average infectious disease person or oncologist will not think this drug is associated with fungal disease, a drug that basically inhibits angiogenesis, proliferation, and metastatic potential in solid tumors most of the time, has been associated in some case series with aspergillosis, even endemic mycosis like Thalassomiasis infections, a drug that really is not considered to be a classic drug to increase fungal risk. Now, let's move to the checkpoint inhibitors and trying to make a more nuanced approach here, whether the checkpoint inhibitors are good, are bad, or really bad. And again, this audience doesn't need a lot of background about the tremendous revolution we have witnessed in our career with the introduction of checkpoint inhibitors in motor oncology that led to a Nobel Prize by our own James Allison. Those drugs are important to remove the T-cell exhaustion in the tumor microenvironment and that for having immune potentiation against the tumor. And this is already an outdated slide, but shows the explosion of approved drugs by FDA in a variety of tumors against a solid organ with checkpoint inhibitors. But even more interestingly, those drugs have been increasingly used in acute myeloid leukemia, with the realization being that there is a lot of immune targets in the blood cells. And interestingly, the hypomethylating agents upregulate tumor antigens, antigen processing, upregulate PD-1 and to lesser degree CTL1 receptors, and they are thought to synergize with the classic checkpoint inhibitors. So there have been a lot of interest, at least in our leukemia service, in kind of high-risk patients to combine epigenetic inhibitors with nivolumab checkpoint inhibitors for relapsed AML. And this is a slide kindly given to me by Dr. Daver, showing in this early experience this combination might result in some survival advantage and durable responses in patients who otherwise will have a very poor outcome with traditional therapies. But then you can theorize that checkpoint inhibitors can reverse T-cell exhaustion associated with chronic viral infections, and there has been a lot of indirect evidence in chronic viral infections such as chronic hepatitis and to some degree HIV that those drugs are beneficial for the natural history of those infections. How about fungi? This has been one of the interesting parts of the checkpoint inhibitors, that there have been a lot of studies saying that checkpoint inhibitors alone can reverse the immune paralysis associated with Candida sepsis, and for chronic fungal infections such as Paracoccidius, Paracocci, Histoplasma, can result experimentally in good responses. And increasingly, preclinical studies with Aspergillus and a small case report with mucor infection, a very difficult mold infection to treat, suggests that checkpoint inhibitors such as nivolumab has beneficial effect. Actually, we have put a hypothesis in the literature that maybe checkpoint inhibitors in AML can heal the leukemia and also ameliorate the natural history of aspergillosis by increasing immune targeting of both the leukemia clones and aspergillus. Based on this hypothesis, this is a paper that is in press in our ID literature. We hypothesize that if you give checkpoint inhibitors alone for in an experimental murine aspergillosis, you can get good outcomes. Initially, we try to extrapolate from the oncology literature, and we use monoclonal antibodies against PD-1 or against CTL4 or in combination by using the dosages that the oncologists use in their tumor models of infections. Typically, the dose in this situation is 2.5 micrograms per kilogram in mice. And for PD-1 and 0.8 to 1 milligrams per kilogram per day for the CTL1 for monoclonal antibodies. What we have shown is when we infected the mice, you get cytokine storm, and those mice are very sick, especially when they're given CTLA4 monoclonal antibodies or the combination of PD-1 and CTLA4 monoclonal antibodies. An observation that has been made in the oncology literature that the combination of checkpoint inhibitors result in profound toxicity in terms of autoimmune side effects. But even the PD-1 that was the less toxic when used daily in full dosages, although it resulted in survival advantage by its own, those mice seem to be quite sick. So what we did next is we decided to give to work only with PD-L1 monoclonal antibody given in 1/10 of the dose of what was used in oncology, 0.25 milligrams per kilogram per day, and every other day. So we gave this attenuated low-dose anti-PD-1 monotherapy every other day, and we have shown here that, as you can see, that this approach gave less toxicity and by its own, without any antifungal drugs, resulted in survival advantage compared to astrotype control and PBS control in murine aspergillosis. And this was translated to less fungal burden in the anti-PD-1 group and less fungal infiltration in the lungs. We play a little bit about, although those data are by far being conclusive with the pro-inflammatory cytokines, but we have seen in this particular panel of cytokines we have run an leukocyte recruiting chemokines in the lungs. This is a whole lung extract that we have seen an induction of TNF, IL-1, and leukocyte recruiting chemokines, consistent with the fact that you promote pro-inflammatory environment that kills the fungus even by its own without any antifungal therapy. And the next thing we did is we say, okay, what do we know about antifungals that by themselves have a pure antifungal activity but also have immunomodulatory activity? And we went back to an early work we have done about 10 years ago in our lab with caspofungin and echinocandins. Those are drugs that inhibit cell wall in fungi, and by doing that, you see exposure of immunologically active epitopes in the fungus, and then you get more immune responses. So we combine this time low dose every other day of PD-1 monoclonal antibody with caspofungin, given typically in these patients, in these mice, analogous to humans, 1 milligram per kilogram daily. And we have seen even a more profound and an exceedingly encouraging survival benefit with a combination of PD-1 monoclonal antibodies compared to PD-1 alone, and this was translated also to less fungal burden in this combination group. Obviously, this work was with checkpoint inhibitors alone and seems to indicate that the checkpoint inhibitors in the right scenarios might be synergizing with antifungals to promote more pro-inflammatory environment against the fungus. Currently, in collaboration with our leukemia colleagues who are reviewing the checkpoint inhibitor database in AML, trying to refute or prove the hypothesis that the natural history of fungal infections, perhaps the fungal risk in those patients is less. But the problem with the oncologist and infectious disease in the setting of checkpoint inhibitor is the subset of patients who have severe immune-mediated adverse effects when given checkpoint inhibitor therapy. And the treatment for those side effects is more immunosuppression with high-dose glucocorticosteroids that need to be tapered very slowly, and for refractory cases, TNF inhibition such as infliximab. This is another scenario compared to all this experimental work with checkpoint inhibitor alone, because those patients have this profound immunosuppression of corticosteroids and or TNF inhibitors. And there have been some reports. This one is one of the better studies, again, retrospective studies, melanoma patients from Memorial Sloan Kettering, documenting that people who get steroids and or infliximab have in a subset of those serious infections, typically pneumocystis if they were not given vaccine prophylaxis or aspergillosis. The average time to infection is prolonged, so these people need to be followed closely for a long period of time. And the typical risk factor for infection was not surprising, corticosteroids and use of infliximab. As noted again and again, the combination of ipilimumab and nivolumab was associated with more infections, this reflecting the fact that those patients had more autoimmune effects and were given more immunosuppressive therapy. To remind you, in our mouse model, that's what we saw. The combination of the two checkpoint inhibitors resulted in profound immune-mediated side effects. So I think the checkpoint inhibitor area is obviously one of the cornerstones of modern chemotherapy, and the infectious risk is interesting and work in progress. Some interesting questions, not the only questions here are how to evaluate best the epidemiology of fungal infection, as typically randomized control studies in oncology exclude patients with active infections. Can we trust the murine models to extrapolate for fungal risk? Because there is a lot of discordance of murine immunology, at least in some elements of fungal immunity with human studies. If you get a fungal infection, can you change checkpoint inhibitor, or can you attenuate the dose, or can you stop altogether? Can you synergize checkpoint inhibitors like we have shown in our experimental work with some antifungals such as echinocandins? Can you see exuberant, paradoxic immune responses like an iris-like phenomenon in some patients with high fungal burden when given checkpoint inhibitors? This is areas that we're working very actively in collaboration with Dr. Daver in leukemia and our pulmonology colleagues. I'm going to touch a little bit now briefly about the area of fungal immunology, because there is an increased realization that currently patients who fail antifungal therapy for opportunistic fungal infections clearly are patients with profound immune deficits. Antifungals, we have enough antifungals, and they are reasonably good despite profound immune deficiency, but I think the missing element of better outcomes is very poor immune responses in the setting of active hematologic disease. And this is an area of profound work for the last 30 years. Fungal vaccines have been an area of interest for some fungi. We have done some work. I don't have time to talk about today about echinocandins as immunomodulators or microbiome. A lot of interest about hypoxia reversing strategies like inhibiting or promoting VEGF, iron depletion strategies. But I'm going to talk a little bit about some work that is evolving with the use of molecular engineering CAR T cells and in the future, hopefully, NK cells. The CAR T therapy is one of the revolution for B-cell malignancies, ALL and other refractory B-cell lymphomas, and you know the sequence here, take T cells from patient blood, creating chimeric antigen receptor T cells that has an antigen recognition domain and a signaling domain, grow them in vitro, infuse them, and see them kill the tumor with or without the expense of cytokine release syndrome. So we have hypothesized that we can engineer T cells, typically CD8 cells, to express a ubiquitous pattern recognition receptor called dectin-1 on those cells that recognize a beta-glucan in the fungi that is a very prominent receptor in fungi, and by doing that, those cells can kill the fungus. And this is work that has been done in collaboration with Dr. Cooper when he was here, and we're continuing this work in collaboration with Dr. Kumar currently. But the bottom line, in this early work, we have found that we have a specific killing of Aspergillus, both in vitro and in vivo, against with the dectin-1 expressing chimeric antigen receptor T cells, and that importantly, something that has been a problem with the CAR T cells therapy overall, treatment with steroids did not result in any attenuation of their activity. And we have done this in two different animal models. One is acute infection model, the lung infection model, and we have devised in our lab a subacute or chronic infection model with cutaneous aspergillosis model. And we have shown, compared to the control being CAR T cells against CD19, our CAR T cells kill aspergillus, improve survival, and decrease fungal burden or the area of infection in our subcutaneous model. Currently, we have new generation CAR T cells we have developed in collaboration with Dr. Kumar, and we're testing both in vitro and in vivo to see if we have new generation of CAR T cells targeting this time not only Aspergillus but also multi-drug resistant molds and Candida. But theoretically, this field might shift a little bit even further, going from CAR T cells to molecular engineer NK cells. And this is basically modification of this opinion paper written by Dr. Rizvani's group that I summarize what I think NK cells have an advantage over T cells. The NK cells target an antigen in a more pleiotropic way, have less potentially inducing graft-versus-host disease. Importantly, that has been one of the problems in logistics. They can be available as an off-shelf product, and it's easy to establish a master cell bank. We can, with gene editing, theoretically, specificity and cytotoxicity can be improved. Importantly, those cells have a very pleiotropic effect against a broad range of pathogens, not only fungi, but also bacteria and intracellular pathogens. And you can manipulate, as I said before, NK receptors as you can do with T cells. So currently, this is a work we're thinking of starting, collaborating with Dr. Rizvani, moving away from cytotoxic CAR T cells to NK cells as a way to enhance immunogenicity of effector immune cells. Finally, I'm going to touch a little bit about an area that has been always in the forefront in oncology, modern medicine overall, including also opportunistic infections such as fungal infections. So the question is, how come all the time you see about 7 to 8% of patients with leukemia having a fungal infection, whether the 92% of them in many series don't? Are the differences in exposure density to fungi? Are the differences in the virulence of the offending fungus? Or are there any subtle genetic differences in immunity, such as pattern recognition receptors, for example, toll-like receptors or C-type lectin receptors and pharmacology? This is an area of intense investigation and debate in our area. And I like this quotation by Francis Collins, who said, for polygenic diseases such as aspergillosis, locating from scratch the gene related to a disease is like trying to find a burnout light bulb in a house located somewhere between East and West Coast without knowing the street, much less the town or street the house is on. So clearly this is a very difficult area to find a profound immune defect that predisposes to aspergillosis, and most of the studies so far has used their own controls, and they were just uh, studies that picked the gene of interest and found an odds ratio of 1 or 2, a little bit borderline significance. The field thinks that well-designed prospective whole genome association studies, realizing that aspergillosis seems to be a polygenic disease, with or without incorporation of validated clean risk models, specific imaging that differentiates fungus from bacteria or viruses. And here, artificial intelligence has done some early steps to try to make some differentiations. This area is far from being mature for clinical implementation. And whether fungal genetics, microbiome will add to this maturation of the field remains to be seen. But a lot of work has been done with classic association studies, microbiome, novel imaging studies, artificial intelligence, and development of validated clinical scores, so we can differentiate and therefore just target a defined prophylaxis to a subset of patients instead of giving one drug for everybody. So I think the questions overall, as we progress to more targeted therapy and less broad cytotoxic immunosuppression, is, and the mycologists of the future might need to deal with these questions one way or the other. What is the best epidemiology in this new era? Here I need to remind that we're not doing autopsies anymore, so always there will be a debate. What is the problem and what is the type of fungus we see in patients who are dying of hematologic disease? How to study the new adenoplastics on the immune system? Do mouse models give us the whole truth, or we should focus on big cohorts of humans based on biomarkers and biospecimens and that we do for malignant disease? And I think very importantly, what is a cost-effective risk stratification? So we incorporate clinical scorecards, immunogenetics, pharmacogenetics that can give us some information about suboptimal drug exposures, combination of the above. So in the future, I think it's going to be even more challenging and more intellectually stimulating for the mycology of the future to evaluate these niche areas of risk and understand better how the fungals work, why the fungals fail, and what we can do to enhance the immune system. So there is basically two ways of looking at this field. When I started my career, the prevailing work was reflected in this nice painting by René Magritte that managed patients as groups, but initially everything looks more reflective to this also beautiful painting, Dutch Proverbs, managing patients as individuals, and this has become also the theme in oncology, genetic predictions, personalized oncology care. This is going to come also and flow down to treatment of opportunistic infections such as mycology. Over the years, I have collaborated with a lot of work, and all the credit is given to my trainees and mentees and my collaborators, and we continue to work on all these areas very actively. So I'll stop here. Thank you for your attention. I'll be happy to entertain any questions.
Thank you, Dimitrios. This was a wonderful lessons because now we have to go back to what we learned years ago, hundreds of years ago from infectious diseases and move it to the patients. It's wonderful research. And I have at least a couple of questions from myself.
Yes.
One, there are markers to predict in the patient treated with ibrutinib and so on, what are the ones who will develop most frequently this infection, accepting this let's say, hematological findings of low level of different cells. There are such type of, let's say, plasma markers or SNP markers, mutation, and so on.
That's a wonderful question. I think that's the next thing based on this clinical review we have done with our leukemia colleagues to see whether those patients, the 3% of these patients who came down with a fungal infection, whether there is any immunogenetic risk that can add it to the precision compared to monocytopenia that we have known for 200 years. Monocytes, macrophage monocytes deal with the fungus or sequential immune defects. We haven't done the studies, but we're thinking now going back to see if we can see those patients who had fungal infections, what if we have an immune profiling of this patient compared to the ones who did not. But this is a very, very important question.
Well, I was thinking to look, for example, to plasma non-small RNAs in these patients, knowing what's happened. The second question. What is and how you see in the next, let's say, 5 years, the treatment of this fungal infection? You think there will be new ways to treat them, new drugs, or what is now it's already enough for the medical?
Currently, there are 3-4 drugs in clinical development. Like with bacterial, one of the problems has been new generation of azoles, like new generation of cephalosporins, me-too drugs, and this has been a problem in drug development. Currently, there are 3 or 4 drugs in phase 1 studies that have a unique mechanism of action and work for fungi that are resistant to common drugs. So I think the typical scenario here is we put everybody, that's the typical scenario in, say, at MD Anderson, we put everybody now, we have a uniform approach, we don't have enough differentiation based on biomarkers or immunogenetics. We put everybody on a very good drug called posaconazole, during remission reduction chemotherapy. 3% of those patients, maybe 8%, depending on how you define breakthrough fungal infections, develop a breakthrough fungal infections. Then we switch classes of antifungals from an azole to amphotericin B, which is still a very good drug, but has its own toxicities. So in this early preemptive treatment of a breakthrough fungal infections, these new drugs might have a role, and those are 2-3 drugs under clinical development. I'll be more than happy in the future to give a whole talk about those drugs. With or without some validated immune enhancing strategies that also theoretically and ideally should promote also the potency of leukemia drugs. That's, I think, the scenario of the future. Early identification of breakthrough in fungal infection, because right now we're a little bit on the dark what type of fungal infection it is, based on PCR-based diagnostics or volatile compound to see metabolic signatures of one fungus versus the other. Switching class of drugs with or without combination with new drugs, and some kind of immune strategy, maybe NK cells or gamma interferon and NK, things like that. That will be, I think, a futuristic view of the field in 5 to 10 years from now.
Thank you very much, Dimitros. So thank you again for your time, because I know you guys in clinic how busy you are.
Yes.
For the attendees, because without you, the attendees, this type of talks make no sense. And with this one, let's say hello, MD Anderson family from MD Anderson all over the world, and see you tomorrow for another wonderful work. And again, after rainy days come sunny days, so be all prepared to make big discoveries, science, clinical, and translation.
Okay.
Thank you all.
Thank you very much. Take care. Bye.
Wonderful.